course, we have Dr. Raj taking us through the medical ethics. Dr. Raj, very, very pleased to introduce you to this very diverse group, one of the most diverse groups we've had on an ECHO program, and a very high quotient of collective wisdom. So I think you're going to enjoy the interactions. Please do feel free to type in comments, questions, etc. in the chat box. I will co-facilitate and take your questions to Dr. Raj at appropriate times in the session. And I'm going to hand over to Dr. Raj now.
Thank you, Smriti. Hello, everybody.
Good afternoon.
Good afternoon. I was supposed to talk to you on your first day. I was cheated out of it. I think it's a conspiracy by Rajalakshmi. Somehow I lost the opportunity, but I'm glad we are meeting up today. I've been hearing all sorts of good things about this group. So I particularly told Raju that I must have the opportunity to meet up with all of you. We are going to talk about ethics. Right, fine. But if you look up any textbook of medicine or anything related, you will find enough there about medical ethics. Smriti, have you noticed when you talk about ethics, spirituality, etc., everybody uses long words. Pardon me, you can find all the long sentences and long words in the textbooks. I'm going to talk about fairly commonplace things. Essentially, I'm going to talk to you, making sure that when my time comes, if one of you is going to care for me, I would get ethical care. So I will go into the 4 usually quoted principles of medical ethics in a moment. But before that, let me tell you about some commonplace things, particularly from our context. Every one of you has gone to a hospital, either as a professional or as a caregiver of a patient, or at least as a visitor or as a patient. Hey, do you think generally as a patient or a consumer of healthcare, you get treatment with respect? The rule, there will be exceptions. Generally, when you walk into a hospital, are you dealt with respect? I much too often find, especially in government hospitals, but also in private hospitals, that respect is often forgotten. Because I'll start from that point. Not the textbook description of ethics. Sorry, I'll come to that. I believe that everybody has a responsibility to treat everyone else with respect. In front of me, okay, the screen doesn't show everybody. Oh my God, there are 64 of the group. But I can see immediately in front of me Alpa. In addition to my friends in Pallium, I see Nivin Bennett. I see Kausalya Nathan. Immediately on my screen now. I do not personally know Alpa, Nivin, or Kausalya. But I'm sure of one thing. Alpa, Nivin, and Kausalya have something in them that I do not have. Maybe Alpa sings like an angel. Maybe Nivin is just simply a much courageous and braver person than me. And maybe Kausalya dances like a butterfly. I don't know. But I'm sure of the 64 people in this group, or maybe more, there are some more than one in some groups, everyone has something that I do not have. And therefore, I believe it's my responsibility to treat everyone else with respect. And that's not only medicine, this is not only medical ethics, this is ethics of living. This, unfortunately, why do I particularly mention this in the context of medical ethics? Where is this respect forgotten most often? When you are in a position of power. Like the politician is very humble at the time of election. But when he gets into that chair, he transforms. It happens to the policeman. It happens when you try to get into an auto rickshaw and the driver doesn't want to take you where you want to go. It happens when you get into a public transport and do not have the right change. You get treatment with anger without respect. That's the imbalance of power. The auto rickshaw driver has the auto. You are in a position of weakness. He has the power. The imbalance of power tends to cause a tendency to abuse that power. Now, how would that translate to medical practice? I don't think there is any other situation where the imbalance of power is more. Here, you hold all the cards. You are a healthcare provider. And as a doctor, especially if I hang my stethoscope around my neck and have my white coat, I am supreme. And the patient, physically weakened, emotionally weakened, pocket empty, maybe even relationships threatened, spiritually destroyed, feeling, oh God, please take me. Zero power. Now, this imbalance of power manifests so commonly in hospitals. And please don't think it's only for doctors. It's whether it's a nurse or a social worker or a volunteer, this comes up. I remembered this once when we were on a home visit with a local volunteer. There was this man with paraplegia. He had he was trying to build a house. He was trying to do as much as possible himself so that he doesn't have to pay a lot. So he had uh, pulled down the makeshift hut, gone into an old unused cattle shed to live, and there was beginning to build a house. He wanted to fell a tree. He climbed the tree, fell, broke his back, and became paralyzed. And he was laying there on a cot in that cattle shed, and the whole family was living there. The wife was now had to be the breadwinner. She had never gone out and worked, had to look after him. And in that environment, which was, I must say, rather filthy, we went for home visit. And the local volunteer with us, in a bit of an annoyed voice, told her, the young woman, in Malayalam, I won't repeat the Malayalam words, but what she said was, hey, is this not where somebody with the patient is living? Don't you know that you should have to keep the surroundings clean? And I even today remember the look on the woman's face, the intense hurt, the weakness which forced her unable to respond. She stood like a statue for a second and then broke down and cried. That was an abuse of power. If it was empathy, maybe the volunteer would have said, I have seen one of our nurses doing this in actual practice. When we found a patient absolutely in filthy condition, she said, hey, let's clean them up, clean him up. Who wants to join me? And the whole team joined her. One person cleaned up the house and sorry, I was distracted. One person cleaned up the house and the others joined and they cleaned up the mat. Somebody uh, swept the floor and they left the place a bit cleaner. If that is true empathy that we may all may not be able to do, but finding fault with that woman was cruel. This is the abuse of power that results in lack of respect. Oh, I'm taking too long. Smriti will be annoyed with me. 3:11 already.
Not at all.
Just one point mentioned. Hey, who wants to comment on this? Anybody? Any comment? Oh my God, 21 comments on the chat box.
Mostly introductions, Dr.
Okay, okay.
Don't worry about it. Yeah.
So if there are any comments, you will point out. Huh? Okay, thanks, Smriti. That's one. Another oft forgotten, especially in our context, in the Indian context, is confidentiality. I don't have to say that. We all know that. We need to respect the confidentiality of the person. If the person tells me something in confidence, I have the responsibility to respect it. The only occasion when I may have to break it is when it is a life-saving situation. Otherwise, I have to respect confidentiality, and this need not be overt. Just casual chit chat within the team. Okay, confidentiality doesn't mean that I will not disclose it with Smriti and Raju. They have to know who else is sitting with Raju. Is it Vijesh? I have to tell them because I may not be the only one to treat the person. The team needs to be involved, and but between us, we'll respect that confidentiality. And casual chit chat among even within members of the team who need not know it is wrong. I remember that one of my patients, a person in intense agony, physical, spiritual, everything. She was on the verge of a divorce because her man was abandoning her. And one member of the team casually went to her and asked, hey, what's happening about the divorce? No, the patient never forgave her because that she was not part of the management team. She didn't have a business to know. She didn't have a business to ask. That question came out of vulgar curiosity. So confidentiality is so very important. Uh, Raju, please don't be angry with me. Quick story. I had this another young woman who was a single mother, two teenage children, living in those in Kerala will understand what's a Lechambid colony. This is a colony for homeless people that the government used to build. They would find 2 acres of land and the whole lot of them will be filled with small huts and given free. Unfortunately, the way it was done, they eventually turned out to be where all the Antisocial elements were there and criminal activities, etc. She lived in one of those huts. Finally, life was so hard for her and she went abroad. She got a job as a maid in a Gulf country. And luckily, she got into a nice uh, home where she received kind employers. But a few months later, she started having itching all over the body. Then they started breaking down as ulcers. And healthcare there is so expensive. The kind family spent their own money and sent her back. She came here and got medical attention and was diagnosed to have an autoimmune disease. It was something called systemic lupus erythematosus. Now, the panchayat member, the kind man in that neighborhood, because he knew the doctor, rang up and asked, "Hey, doctor, this person belongs to my community. Okay, what's wrong with her? I hope it is nothing serious." The doctor said it is not a curable illness. It's a kind of immune suppression. But we can continue to treat her with medicines and she'll be reasonably healthy. The panchayat member caught hold of one word, immune. The next day, the whole of the colony knew that so or thought that so and so had HIV. That's a news that spread. So thoughtless disclosure of information can cause calamities. I have seen a carelessly laid patient's file uh, left on the desk being seen by a family member and resulting in a huge problem because a note was made about a quarrel between the person and the daughter-in-law. So confidentiality is most important. I mentioned respect, I mentioned confidentiality. Ah,
Dr. Raj, in the chat box, twice now the word dignity has been mentioned, which is also extremely important, and it's been mentioned in the context of power being misused and abused. And I just thought that if you want to talk about that for a moment.
someday, when I am your patient, this is one thing that I really think, despite all our discussions, will happen. I'm an old man. Somebody wants to do a catheterization on me. They may not take that much of care about drawing the curtains around me. After all, it's an old man. What does it matter? And particularly, thanks, Madi, and thank you, people who mentioned this. See, so many people are poor in our country, but one thing that they hold very often dear to them is their dignity. They carry that dignity with great courage and value. And many people, I have seen people starve without asking for help because they think I shouldn't beg. And hospitals, thank you for pointing it out, are places where dignity is offended in the most horrendous way. From the gate, the person at the gate, to it, to the uh, to the hierarchy, up to the God, and beyond that to the doctor, everybody offends the dignity. Thank you.
If I may also add to that, there is the assault on dignity from that angle, but we have to be mindful of the fact that in our eagerness to help, we also sometimes offend the dignity of somebody. And what I mean by that is when we go in to help in a manner that is, if there's an element of self righteousness or I'm better and therefore I'm coming to help you. We're careful how we use the word help. Not everybody likes to be helped. And Dr. Raj, if we can also hark back to that phrase that we use a lot, that quote by Pema Chodron, that compassion is a relationship between equals. It's not a relationship between a healer and the wounded. So we have to be mindful that in our eagerness to help, we are not inadvertently making them feel worse about themselves. That very paternalistic pat on the head, or that patronizing tone of "I'm here to help you because I'm in a better place than you are." So that's something I just wanted to point out.
Thank you, Smriti. Well said, and a beautiful quote, of course. And I may add, sometimes, with all good intentions, we use humor to get over difficult situations. I mean, joking about the patient. And humor, it's a great coping strategy when the patient uses it. But when we use it, it may feel very offensive to the patient. And that's another way of violating their dignity. Uh, okay, I'm tempted to tell stories, but I need to push on. Okay. We mentioned respect, we mentioned confidentiality, we mentioned dignity. And one particularly difficult thing is being non judgmental. I once had a patient with a peripheral vascular disease, gangrene. You have seen that kind of thing. One of the most horrendous things to have. If I was offered a choice between gangrene and cancer, I would go for cancer any day, because lack of blood flow to the tissues causes such agonizing pain, which sometimes you don't see anywhere else. So this man had gangrene and he suffered for horribly for 1.5 months. Very unpopular patient, always shouting, insulting people, screaming. Uh, and finally, he got an amputation. And then, as the wound healed, his pain was gone. Mostly, he had some phantom limb pain, but otherwise. But he had no family, nobody to care for. We knew he had a family, but nobody came. We found it very difficult to trace them. We wrote a letters they were not attended to. The phone calls didn't get us anywhere. And we finally contacted the post office, sought the help of the postmaster, and connected to the postman, who went and talked to the family. They said, "We don't have anything to do with him. We are not coming to get him." Uh, we requested the postman, "Please get us connected with the panchayat member." The panchayat member took the phone and said, "Oh, that guy. Okay, he has lost one leg. Huh? Send him over here. We'll break the other one also." This man was a drunkard, a thief, according to the panchayat member, wife beater, would physically uh, punish his children cruelly, and was a general nuisance. Nobody wanted him. So when he is also offensive to you, Purnima, what are you? I'm picked on you only because I see you on the screen now. You were not there earlier. What are you? If I may ask you, will you please unmute?
Yeah, can you hear me?
Yeah. What do you do?
I'm a counselor, doctor.
Purnima, this patient is a classical patient who may get referred to you because nobody else can deal with him. They all think you perform miracles And Purnima will talk to them and convert them and make him a very nice person. That's what we laymen expect of you. So, and you find yourself being verbally abused by this man. There's nobody who wants him. It's going to be very tough to be non-judgmental to him. Now, one of my colleagues once said about that was about another patient, that of all the lessons that she learned in palliative care, the hardest is not to be judgmental. But this is a very important lesson for us, because think from that person's point of view and think from our point of view. Purnima could be the only person in the whole world who can still give him some compassion. He's not going to get it anywhere else. And from everyone else, this will be demanded someday. We will all come across these people whom no one wants. And I hope, I also struggle with this. I struggle with this because the behavior makes me angry. When I am angry, I am not reasonable. And I may not be able to achieve this, but I'll try to remember that I am in a particularly demanding situation here, where my sense of right and wrong should hold true. Here is a human being very much needing of care, and whether he insults me or not, I have been given the privilege of being the one person to give him some compassion, and I have to treat him with that, even if he insults me. I will also remember that I am a human being. I may not be able to do this. I may be, my anger may tempt me to retaliate. But at some point, if I do, the next day when I am not angry, I will go and apologize to him. We mentioned about respect, dignity, confidentiality, and being non-judgmental.
Yes.
And just one more thing, and I'll go to the official discussion on ethics. And that final point is needing to put the patient at the center of our institution, of our service, of our work. Pallium India should never become bigger than her or him. If there is a conflict, we should keep the patient at the center. Again, this is difficult. The patient at the center, the family next to me. Hey, how about the team? The team is doing such marvelous things. Vijesh and Raju work so hard and risking their lives by coming to work in this department when the community spread is rampant in Trivandrum. Isn't their health important? Isn't their welfare is important? Of course, that is so frightfully important, but not more important than the patient and family. That doesn't mean that we will not take precautions and go and care for patients. Whenever this conflict arises, we will try to remind ourselves that we will consider the patient the most important consideration. Our own frailty as human beings, our own emotional weaknesses may fail us. Nevertheless, we will try to remember that.
Dr. Raj, there is a very important question from Rajni, Dr. Rajni. And from previous sessions, we know that Dr. Rajni is new to palliative care, but already an advocate. So her question is, sometimes due to globalization and cultural differences, we may inadvertently offend. So are there any specific phrases that we can use? And because this applies to any patient, not necessarily palliative care.
But Smriti and I have an arrangement that any difficult question will be handled by Smriti. But wait a minute, Rajani, we can't possibly have an answer to this during this session because such a huge area. What is totally acceptable in my part of Kerala may be totally unacceptable in northern Kerala, leave alone the world. This is challenging. But I will tell one thing to Dr. Rajani Shashumar. Rajani, you and I need not always be right. We are human beings. We will go wrong. We are not perfect. Rajani, I haven't even seen you, but even without seeing you, I am making the statement that you are not perfect. We are not we are human beings. It's okay. We will try. We'll remember to not to offend the patient, to respect the dignity, and we will try our best. This happens very frequently when we have, especially in USA, maybe imagine a hospice. All of a sudden, a Jain patient goes into from India, goes in there as a patient, and I can almost imagine the palliative care physician and now looking up the textbook, cultural context, Jainism, and there will be 3 lines there. And though they will study those 3 lines and practice the appropriate philosophy, which is actually a joke. We cannot know, but we will continue to remember the language of love. That is universal. They will forgive you even if you make a mistake in the particular cultural salutation. That's okay. Oh, thank you, Rajani, for the personal comment, and I'm sorry that I'll look for you on the screen later. Thank you. Hey, Raju is getting very, very annoyed. I think I should go on with my presentation. We mentioned the textbooks. You go to medical ethics, which will deal with the, okay, I won't repeat the long words and definitions, what is right and what is wrong. I'm trying to share the screen, okay, Raju?
Yes, sir, you can.
Thank you. Oh, sorry, okay. $333. Are we dangerously late, Raju?
No, sir, we are not.
We don't have a case presentation today.
No, we don't have.
So I can make these numerous case presentations in between.
Yes, sir, you can.
Hey, look at this poor person in the bench financially. Poor, impoverished household, elderly lady.
Sorry, Dr. Raj, can I just ask you to go into slideshow mode, please?
Of course, thank you. So, ignored ulcer in the mouth, ignored. 2 years later, diagnosed to have cancer. The hospital said she needs surgery. Half the jaw is to be removed. Half the jaw is to be removed. Okay. If you are ready, sign the form, consent form. We'll try to do next week after next. The patient, of course, vanished. What will life be like without half your jaw? A gash there? What does it look like? Won't her grandchildren be afraid of seeing her without a face? She said no. And now She is before you for pain relief. She has exercised her autonomy. The first overriding principle of medical ethics, autonomy. One's right over oneself. These are the 4 fundamental principles of medical ethics. Individual autonomy. This is my life. I have more right over this than you, doctor. Beneficence. I'll try to do the best for the person. Non-maleficence. I'll try to avoid harm. And justice. In this context, distributive justice. Whatever we have, the resources we have, has to be spent fairly, equitably, not equally, equitably, depending on the need. And always you will notice that autonomy is mentioned first. My life, my right. So, Paru Chechi has made the choice. I don't want surgery. Give me pain relief. Okay, so what should I do? Shall I start pain management and continue to provide her with palliative care for the rest of her life? Is that okay? Can I see comments? Smriti, once I put on slideshow, I will not see the chat box, so you will have to read it out.
I'll do that, Dr. Raj.
Thanks.
So you're inviting people to give their comments to your question just now.
Of course, I must give pain relief. And I'll respect her autonomy, give her pain relief, and continue like that. You have any comment about that or no?
Try talking to her and make her understand the importance of surgery is somebody's comment. More people are saying you can convince the patient for surgery. Somebody has said, I feel we should explain to her the benefits of surgery and explain what is the plan, the further plan. Alpa says, respect her wishes or help her understand the pros and cons. And Sandamita says she will be informed about the consequences. Shreya has made a point saying, understand her fear first, ask what she wants. Wow, okay, the responses are coming in very quickly. Patient's choice has to be respected, but also it's important to educate her about what can happen if surgery is not performed. And Rajni says, find out why she does not want the surgery. Sandamita says, let her come to an informed decision. Maushami says, why is she denying surgery? Try to unveil that. So basically, people are saying explore her fears. Some people have said maybe lay out the pros and cons and then allow her to make an informed decision. And others have said convince her of the surgery. So 3 broad categories, Dr. Raj, of responses.
So, yeah, more than one category in the sense, almost every response that came in indicates that it is not enough just to blindly respect autonomy. Okay, you don't want surgery, so here's your morphine tablet. That is wrong. You all say that in one voice, you all say that that's inadequate. Respecting autonomy should not be done blindly. She has a right for information. The problem with starting to explain immediately, you Parchechi, that's not enough, that's not okay. You see, you have a curable cancer. You must undergo the surgery. I don't want surgery. No, but I mean, like this is wrong. This is not the way to do it. I mean, you are taking a rash decision. It is not rational. Please allow them to proceed with surgery. I don't want surgery. So I would rather go by what Shreya, Rajani, and someone else mentioned. Before lecturing her, find out why. Autonomy shouldn't be blindly practiced. We should listen to her story. But there's a problem. You see the way she is lying? Do you expect her to be very talkative? So, in answer to my question, I will also say that when you are in agonizing pain, pain is so all consuming that you cannot think straight. Raju, please remind me after the session. I have a link to an article by Dr. Divagaran, which we will send to everybody so that they can see the article about an actual situation where a patient went on refusing surgery. But once pain relief was given, okay, they were willing to listen, take an intelligent decision. So maybe there's a point, this woman needs pain relief. That has to happen. Not as lecture when she is already in so much of pain. Then we should find out what her point of view is. What is she afraid of? It may be just disfigurement. What is it? What does your beauty matter at this age? Could be a very insulting. That insult added on to that her injury. That kind of thing gets spoken often. And Bijesh, if you have not read the book, uh, My Mother Did Not Go Bald, in our library, please read it. It was written by Naseem Begum, the daughter of one of our patients. I think My Mother Did Not Go Bald is available. I'm doing a little promotion. Okay. Um, uh, uh, it's so important to respect her dignity. If it is her disfigurement that she is concerned, maybe we need to explain what would be the solution. And we need to understand them, and then only autonomy will be humane autonomy. Otherwise, it is blind autonomy. So respecting autonomy will be also done mindful of the other principles. We also have the duty to do good and not to cause harm. By not listening to her, by not giving explanations, we are not being beneficent and we are causing harm. So autonomy is still overriding. Okay, I'm creating more difficulties for you. I am your patient. I have said no surgery. And you ask me why. Oh, I am 73. I have had a good life. It's okay. I don't want to spend the rest of my life in a hospital. You treat my pain, I will stay home and die. And then you give some more explanation. Shreya really has a lot of affection for me. So Shreya spends half an hour trying to persuade me. And I say, Shreya, enough, no more. My mind is made up. I do not want surgery. What will you do? Please think up some answer while I take a minute break.
So that's a question to think about. What happens when somebody we care about is adamant, and what is the impact that it has on you from the perspective of someone who is their well-wisher and wants what's best for them? But beyond a certain point, you reach an impasse. And where does that leave you? How do you feel? Think of it from the point of view of being a professional care provider, as well as being, I mean, when you see that happening in a family, and also put yourself in the place of that care provider in the family setting. So if you can just put in your comments, we'll pick them up when Dr. Raj is back. Also, from the point of view of the caregiver in the family, respecting the feelings of that person, there's another dimension to it also, isn't it? If that person's decision to not undergo treatment or surgery will result in their in their death for certain, it is also a loss that we as caregivers experience. So it's as much about ourselves as it is about the person that we are caring for. So there are two levels to that, are there not? So I invite you to also share your comments about that. It's not always easy to respect the decisions of people we love. In fact, that's some of the most difficult decisions to respect.
Thank you for your patience, everybody.
Dr. Raj, we were just chatting about what happens when the person decides that this is what they want and nothing more. So I'd ask the group to think of it from two perspectives. One of being a professional care provider who sees this in families, and one from being a family caregiver, where it's oftentimes very difficult for us to respect the decisions of the people we love, because it also means a loss for us. So I've invited some comments on that.
So that thing about wait a minute. I'm trying to ensure so that I can see the chat myself. It is the first visit. Give the patient some time, Shreya. Shreya, when she goes to a restaurant, takes 5 minutes to choose between aloo gobi and butter paneer. And very often we expect instant decisions. And the more you are arguing with me, the more my mind is been made up, because I am such an adamant, headstrong person. Yes, of course. Maybe what then Shreya would do is to tell me, look, it's your decision, of course, after all. Nobody else's decision. But please do one thing. Please give it some time. Let us talk again on Monday. Absolutely. The patient has some passive death wishes, depressive illness. Death wish. In our culture, very often there is this culturally, in Jainist belief and Hindu beliefs, there is this often a decision that my life is complete, it's time to go. And sometimes that kind of belief has to be respected too. I'm not saying that warrants euthanasia, but we will try to understand the person's point of view without being judgmental. But keeping arguing in favor of surgery is not the answer. Finding out her reason, and then one more thing I may do, not today, day after tomorrow, or tomorrow when I meet her, I will say, Parajeji, I know that you do not want surgery, but do you really know what's likely to happen if we do not operate? The next, what's the consequence? The consequences can be terrible, that this thing will break open, and then we will try our best to keep it as clean as possible, but there's going to be a foul smell. You will not be able to swallow even water. So these are some of the consequences of not having surgery. And that I will try to be as gentle as possible and then I'll give her more time. Okay. So coming back to my slideshow, we will continue to respect autonomy. My wife, my son, or you, the doctor, do not have more right over me than yourself. We will always respect that. But one more point. In her case, actually, part of the problem was that she was saying, don't operate on me because she didn't want to burden the son. And the son had no money at all. The surgery, because she was below poverty line, would be free in the hospital, which means that she wouldn't have to pay a hospital bill. But there are always so many expenses, right? They will say, okay, this medicine is not available. This also you will have to get. Oh, tomorrow is your day of operation. Bring these things. There would still be a financial implication. One of the things that our organization very often struggles with, as everyone will, whether even a government, how much will you give free and how will you spread it out? This question came up. A donor, a valued donor of ours came to us seeking support to raise money for a kidney transplantation for a patient. They needed 20 lakhs. They had already got 5 lakhs, 20 lakhs more. They wanted our support. Can Pallium India fund a kidney transplantation? In this case also, these issues come. Many of our patients have these problems. They need chemotherapy, they need radiotherapy, they need some money. Somewhere we will have to be fair in allocation of resources that we have. So you don't know what to do. You are in a dilemma. This is a very good thing. If you could do it, what will you do? What choice will you make? So what I do, I'll tell you. When I do not know the right thing, the decision is not taken by one person. I may be the chairman of the organization. That doesn't make me God Almighty. I may be in doubt. I'll get 2 more people. And in every ethical doubt, we have a committee of 3 people from 3 different areas whom we can bring up. Usually they give a decision within a day, an ethics committee. Not your research board not your ethics board for research, but another committee to apply for applied or practical ethics. I hope the answer about this is the earlier point is clear. What am I doing wrong now? That if she refuses surgery, I have to find out why. It's up to me to treat her pain, get her to a state of as near coherence and ability to think as possible, and then give the best advice that she is willing to receive. But if after all that, hey, doctors, I continue to say I don't want surgery, you will have to respect that. You will have to respect that anyway. What will you do? Bind me hands and feet and take me to operation theater? It's my choice. But please respect my decisions, even if you are convinced that they are wrong. Anyway, you have no choice. The saddest situations that I find are when a patient is taken to the ICU. Patient keeps begging, Please don't take me back there. But all the family colludes with you, and you take the person to the ICU to die alone there. That is horrible violation of autonomy. I will keep on trying to argue the patient's side. I will not be a party to it. So doctors particularly, or anybody, you even if you are not the primary decision maker, you may be in that situation. When there is this conflict, the family is powerful. They override the decision of the patient. What will you do? Leave alone that, any decision. Another one that I came across recently, the pediatric oncologist had said that so chemotherapy will be no longer useful. They want the child, they cannot give up the child. We must try our best. Doctor, please give one more chemotherapy. Let us try. Give one more. We are asking you. He is but a child. We are asking you. The child is saying, very angry, not speaking to anyone, and they are forcing you. What should you do? Essentially, I am asking if the family or even the patient forces you, patient is autonomy, try to force you to give a treatment which you think is not the patient's best interest, which you think may be harmful. What should you do? Including that ICU or that one more chemotherapy, what would be the right thing to do?
We're just waiting for some responses to come into the chat box, Dr. Raj.
Yeah, I'm waiting.
Mausami says we should talk to the family members. But that's very, I mean, to the point you raised, Dr. Raj, it's almost like when people in our family get a physical disease, we assume that they're incapable of making other decisions. So very often that happens. Sunita says, you should not give chemo, make them understand patient is not fit.
Okay. Second opinion from another doctor, counseling will help or explain in detail. Okay. Your rights, your responsibility also needs to be respected. No one can force you to do something that you believe is wrong. And what you will have to then say is, I truly believe that this will be harmful for the person. I will refer you to another doctor. Please consult somebody else. And please come back to me if you want us to continue the treatment, but this I will not do. It happens, this situation comes up, they will be very angry. You cannot always please everybody. But if I feel fairly certain that something is harmful, I can never be 100% sure. But if I feel that it's reasonably certain, I have also my autonomy. The patient's wishes are paramount, but not at the expense of making me do something that I believe is wrong. Essentially, the care must be a partnership between the patient and the caregiver provider, and uh, the violation of that is not acceptable. But how about this situation? So, shall we go ahead and do this? I don't know what to do. You tell me what to do. I will do whatever you ask me to do. He is giving up his autonomy. And actually, some doctors are paternalistic and do whatever they want to. Others say, no, I can't decide. You have to decide. What should be the right thing? In such situation, I think we need to be on their side. And I may say, well, if I were in your position, I think I would go for op radiotherapy. That much responsibility we have. Autonomy is not to be practiced blindly either way. When they need our help, they are asking us the way they would ask a friend or a guardian. And that advice we have to give them. Not saying that it's your choice, I can't do that. Or the patient may say, I've actually come across this several times. And smilingly, a man said, "അകത്തുള്ളവളോട് ചോദിച്ചോളി." You ask the person inside. The person inside is the wife. People give it up. I don't want to take these decisions. And that's okay too. If again you will give them time, I'll certainly ask her. But I would like you also to think about it and ask me if you have any questions. And then we'll try to come to a consensus. And I already said the painful thing, when the family forces you to do wrong things, we will try to avoid it. We'll remember that that son is not our primary client, it is the patient. But we'll also remember that I cannot afford to make him an enemy. That son is important to me. Because if he is an enemy, I will lose the chance to help this man who needs me. This has happened. One family brought a patient, and the family member came in first and said, "My dad is sitting in the car. I'm going to bring him. He needs to have his pain treated. But I don't want him to know that he has cancer. Please promise that you will not disclose the diagnosis to him." And only after that, he's willing to bring him from the car. And what I said was, I promise that I will not tell him now. You bring him in, I'll treat his pain, and about future course of action, we can discuss and decide. I think before winding up, two important points need to be brought up. Informed consent. Respecting autonomy means doing anything only with the consent of the patient. So I want to give the patient morphine. Should I take an informed consent? Smriti, are answers coming in?
Just now, they've just started coming in. Parul says most are illiterate. So, ... Rajni says not for pain relief. So far, there are those two. And Vandana says if the patient needs an immediate intervention, then yes. A question has been raised. Will they even be in a frame of mind to give an opinion?
So, Rajani said it is not necessary, not for pain relief. Let me expand on that. When somebody is coming to me for treatment, there is something called implied consent. They are coming to me because they know that I will give pain relief, I will look after them. So for giving every medicine, should I take informed consent and get it signed? That's absurd. So the courts will also support you. Consent is implied when somebody comes to you for treatment. So anything out of the ordinary or invasive procedures should be done only with informed consent. But that's a very interesting point. How about illiterate person? Implied consent is there for ordinary procedures, so there is no need to mention that. But here is a question. Illiterate men may not be able to read and write, but should the person be still told, we are going to give you morphine? The word morphine may scare people. Shall we just dish the tablets out without saying that it is morphine? More responses needed, please.
So consent can be verbal too, is what Rajni has said. Alpa says yes. Shreya says, well, she said yes, then she says no, it has to be told. So earlier Kausalya had said explain and give it. It has been mentioned that it should be told that it's for pain relief. Why it should be given and explained very broadly. No, Rajni says, I don't think we can sedate without consent. I think we're not, sedation is a slightly different topic. The family can be told and patient too, just to ease the pain. So these are some of the responses that have come in, Dr. Raj.
Okay, thank you. Rajani, that technical point, morphine, when given, especially when given orally, in doses adequate for pain relief, does not cause significant sedation in the majority of patients. So unlike what we practice when we give anesthesia, here the dose is titrated in such a manner that people, 2/3 of people will continue to function and even go to work. Some people even drive. But 1/3 of people may feel a bit sedated. So it's not the same thing as sedation. But illiterate or literate, if I am the patient, I have a right to know. It's as simple as that. Literacy is not synonymous with intelligence. And you will find that when you speak their language, some of these illiterate villagers are able to handle truth much more courageously than the sophisticated city, educated city man. They have gone through a lot. They can understand. Generally, I mean, whether it's poor or rich or literate or illiterate, there will be some people who are weaker than others, but they still have a right to know. That written consent may not matter, but they still need to know. If you think I want information, I should be given the information. It should not be concealed at all. I need to understand. If I am scared by the word use morphine, please explain to me. Don't assume that I am stupid, even if I am illiterate. But that's in addition, there's a practical point. If you conceal it, imagine what will happen. The person will take it home, and the neighbor, a doctor or a nurse will come, morphine, and that will be the end of it.
Dr. Raj, may I interject also to just raise a point that how we communicate with somebody is very vital here. We have to meet them where they are. We cannot be using, I mean, even for an educated person, if we speak to them in jargon, they're not going to understand what they're agreeing or disagreeing with, right? And similarly, so I don't think that, so it really, the onus is on us as healthcare providers to find the language that is on their modality. And then, so it calls for a little bit of creativity and a little bit of patience on our part as well, to be able to explain it to them in the way that they understand the pros and cons clearly enough to give consent.
Thank you, Smriti. And I'll add, even when we have linguistic difficulties, lack of communication, etc., the language of love still is understood. Your face, your eyes, the care that you show, your body language, all will matter. And particularly about the illiterate, the Helsinki declarations generally keep getting reviewed and are the gold standard in ethics. If the consent cannot be expressed in writing, non-written consent must be formally documented and witnessed. And one of you actually said that. If a surgery is needed and it's an illiterate person, rather than getting his thumb impression, it's so much better to document that this was explained to the person because he is illiterate, he cannot read or write, and sign it yourself and get a witness to sign. So I'll skip this. There's already a few things that I have mentioned. Distributive justice also I have gone. So we'll spend a couple of minutes on euthanasia, and then I leave the floor open for questions. Smriti was not here, Shreya was not here, Raju was not here, Vjesh was not here. Just before that, I had this man come to me. Smriti has possibly talked to the wife, but I will not disclose who that is. So this man with a very severe chronic pain and obstructive sleep apnea came to me. He could not take most painkillers because that would worsen the obstructive sleep apnea and he cannot sleep. He could not use a CPAP device because for the sleep apnea because of his neck pain. Very complicated situation. He did not come to me for pain relief. We made the introductions and he said, I know you will not perform euthanasia because it is illegal. Just verbally tell me which is the best way to commit suicide. Advise me. I am scared. I am scared to take medicine so that if I don't die, I'll be in a greater problem. And this business of hanging is something that I do not want to do. Even the thought scares me because of my neck pain. Please tell me. And I was taken aback. And I looked at the wife. And she said, it's okay, doctor. I've seen him suffer for all these years. I don't want him to suffer anymore. Let him go. Sometimes, even though you see hundreds of patients, some people surprise us. All of us are used to people begging to be killed, but they do it because of their pain or other suffering. You treat the suffering, they sit up and smile. But here is a man who's gone through this for 15 years, has very clearly thought things out between the two of them and decided to go. What should I do? Respecting his autonomy will be quietly telling him, you can do this. I know what can be done. क्या करूं मैं? Shreya is smiling at my Hindi. I am waiting for the answers by chat to be read out by Smriti.
It's just starting to come in. John says you need to respect life no matter what. Alpa says listen to him without.
Wait. Don't. That's your belief system. You have a right to your belief system. True. But you do not have a right to enforce your belief system on me. Right, doctor? Thank you. Thank you, Dr. John. I know you can do it. That's your belief system. Okay, let me go and try find somebody else. That's what I would say. Okay, but I totally agree that I can't do anything again for request you to do something that is not in tune with your belief system. Okay, next.
Rajni has asked whether euthanasia is legal in India. We can circle back to that point in a little while, Dr. Raj. So Shreya, the other Shreya says the pain is his. We need to respect that. Parul says prolonged illness causes financial burden to the family, so patient thinks of ending their life. Rajni's come back to say, moreover, doctors try to save lives, and as Nivin has said, cannot cause harm. So let's work with these for the moment. And Vandana has said this is a tough situation, but euthanasia being illegal can't be discussed. Sunita says, first of all, place your hand on him, look in his eyes, tell him he's not alone.
That was beautiful. Now, here was a man who was still working, mind you. You would have believed that if he was able to go and work a little bit, he should be able to look after himself. But 15 years of agony, not having a good night's sleep ever. Anyway, many of your opinions are correct. We should give him pain relief. You are not alone. The important message. Essentially, that was not the only thing that I turned out to be communicating to him. But the majority of people, you find out the problem, why, and then the problem is solved. We are able to remove the cause of the suffering. But Rajini's question, no, Rajini, euthanasia would be murder. So even if I tell him, okay, this particular drug combination should be good, then I am being a party abetting suicide. Interestingly, in India, very recently, suicide is taken off the list. It's not no longer a crime. But the old law stays. Abetting suicide continues to be a crime. Anyway, that's the legal part of it. But legality alone, this was one of the most troublesome ethical issues that I've come across. Because here, I went on trying. Look, okay, I Mr. So and so, I'm sorry, I can't do that, but I want to try to help. Here are a few suggestions I have. One, oh, I have already tried that out. Two, oh, Dr. So and so, the expert in Coimbatore, already said that he cannot do it. So he had gone through the drill, most of the things he could not do. And there, you said, don't tell him you are not alone. That's not exactly what I said, because he is alone with his pain. I said, look, there right now I can try this, and this, including some myofascial trigger points that I can try to reduce your pain. I can also talk to so and so and try to get a consultation with so and so to see if they can help. I'm sorry, I cannot help you to die, but so long as we are here, we will try to work with you to find any possible solution for your problem. And if there is any worsening of the pain, we will again see you to see what we can do about it. The man continued to come to me practically every month. Yes, mentioned. I'm sorry for that complicated answer, but it will be less complicated if we start from this end. First, I had to see what was the facts of the case. The sleep apnea, the pain. I needed to evaluate them again. And eventually I found that he was right. There was nothing that I could do about it. What is ethically right? His autonomy is demanding that. But I also, in my mind, when I saw him, I thought, this man really deserves to die. So much, going through so much. And the pain on his face and his wife was something that touched me in there. But I couldn't do it. We have to look after the societal points. What does the society think right? Even if some people think euthanasia is justifiable, our society as a whole has rejected it. The economics of the situation was not valid here. But this is what we have placed final. This is from my friend Dr. R Rajagopal from Chennai. This decides it. I cannot do anything illegal, and he cannot expect me to do anything illegal. I did not do anything illegal. The man continued to live in pain till he finally got a heart attack. Unfortunately, the saddest thing happened. He was made to lie down in an ICU where he was desperately uncomfortable. And he continued to be uncomfortable. The wife pleaded with them, let them out, let me take him home. It doesn't matter. And they wouldn't discharge him. She was powerless. And he died in pain in an ICU. So, what am I telling you? There will be these difficult situations where you do not know the right or wrong, where the situation can be beyond your ability. Do what I did. Get my colleagues' help. Let us not do this alone. We need company too. We are also in difficulties. We will also be in emotional pain. We need teamwork to handle such situations and to decide on the right and wrong of things. I see that we have 10 minutes left, during which I'll take questions. And if necessary, anything is necessary, I'll come back to the screen. But much better to see everybody now. Rajani says the cross that intensivist has to bear. Rajani, I have been an intensivist. If I was in this situation, I would have written down the facts of the case on the file, and I would have taken that responsibility to send him out of the ICU, to be with his wife, and to nurse him in his last day. Uh, there are Rajani is still worried about very much. Yeah, Rajani, this was a very well-to-do patient. As fact, he was he was a senior member of the Lions Club, um, who used to enjoy his drinks till he got obstructive sleep apnea. They had gone through all options. That combination of his cervical spondylitis, intense neck pain, and this gave him that deadly combination. No solution for the pain, no solution for the obstructive sleep apnea because of his neck problem. So that was explored. Okay, not specifically about this question, but anything that we discussed today. Vandana, in a philosophical sense, has less. Life and death are not in our hands. Hey, doctor, I thought you are next to God. Next to God, above Him, actually. Uh, yes. We all realize, the whole medical system realizes that there would be situation where we are helpless. And then the only lesson I have learned is not to abandon the patient. I have told patients honestly, I have done all this. I know nothing has helped you enough with your pain. And one patient actually said, don't tell me not to come back here. And when they are very often don't say that, when they are look desperate, I tell them, we will continue to be here for you. when you need us. And though I have not been able to help with your pain, we are here with you. If I can walk a few steps with you to ease your pain a little bit, I will do that.
Dr. Raj, do you find that a lot of the times the exploration of the fear, no matter what situation you've discussed today, if we explore the fear behind that thought process, oftentimes leads us to what it is that is worrying them. And we also have, there's a difference between fear of dying and how the death will occur, right?
Smriti, you are talking about in the context of a request for euthanasia. Smriti, I did not understand the context in which you are making that observation. Have we lost Smriti?
Yes, sir. We have lost Smriti, ma'am. She will be joining in soon.
So Rajani, Rajani has a lot to discuss with me. It seems that we are all friends, but with my dementia, have forgotten her. Raju, please give me Rajani's email ID. We have a lot to discuss.
Sure, doctor. Smriti, ma'am, we have lost you in between. Can you repeat what you said? Yes.
Smriti, I think I heard you, but I did not quite understand in what context you made that statement. Can you repeat that?
No, which statement? I made a couple, and I don't know when I got disconnected.
Oh, okay. Hey, somebody help me.
About fear. Okay, somebody has said fear. So what I was saying is that usually
Explore the
there is
fear.
a fear behind the anxiety, right? The fear behind the anger, the fear behind a decision. So exploring the fear is usually key in helping us understand what it is that is causing that particular thought or causing that particular emotion or causing that particular decision to be so stubborn about a decision. And the other point I wanted you to talk about was the difference between fear of death and fear of how the death will occur, and how oftentimes we don't explore that difference for people.
Okay, Smriti, why talk about them? Let me talk about me. I am not afraid of death. I am afraid of the dying process. I am afraid that my doctor, even my palliative care doctor, would be too concerned with my safety and not about my comfort, and that they will delay a little aggressive pain relief measures or even palliative sedation because they are afraid. I am afraid of the dying, especially the suffering associated with it. The one thing that strengthens me is that I am in palliative care and I know that people who are likely to treat me may know where uh, how to make me as comfortable as possible. That's the one that gives me strength. And I think Smriti has seen my advanced directive. Yes, she has.
Nivin has asked.
Individual autonomy in a child with a terminal illness, and parents want to push further with treatment while child doesn't. Such an agonizing, helpless situation. And the beginning is recognizing that the parents are not your enemy. For all practical purposes, they are now becoming the child's enemy, but they are doing it out of love. They need a lot of help. Very often we come to force them to take a decision at the last moment. If the communication starts early enough, which is why this group is so desperately important. Healthcare, when it is left to doctors and nurses alone, this happens. Very often, communication starts too late. They have no time to get used to the reality. So we have to work with the family legally. There is this thing between conflict between legality and moral right here. Legally, if the child does not come of age, the parents have the legal right to take decisions and to force anything on the child. But as human beings, we also have the responsibility to recognize that the child is an individual. Child's wishes, child's fears, and need to, etc., need to be explored. And we need to respect the child's wishes as much as possible. Very often, at that stage, the child would be very angry with the parents. And sometimes the child opens up to me, but not to the parents. And then the parents get offended. This is a very tricky situation to handle. And it's one of the saddest things that children are often put into great difficulties. The families will take them from one place to another. And the only answer that I can give is not an absolute answer for all situations, is our teamwork so that interaction starts early. This communication is not only a standalone end of life conversation, this should be a continuum. The family needing support to come to terms.
Also, just to pinpoint, Dr. Raj, that further down these sessions, we are covering specifically issues pertaining to children and palliative care in pediatric settings, as well as talking to children about grief. That's a subject that we will be covering in one of the sessions in the future. We're also doing an entire a bunch of modules around the theme of end of life care and death and dying and the ethics related to that. So that's towards the end of this entire series. Just to let everybody know.
So time is up, Smriti, though there are still questions there, but as you say, those questions will be answered in course of time.
Yes. So thank you, Dr. Raj, for a tremendously enriching session. Although you have now given everybody the impression that Raju, Shreya, Vijesh, and I are very scary people, but who are scolding you all the time. But apart from that, thanks for a lovely session. I'm sure we'll have a lot of questions and comments pertaining to your session, which we will take happily and share with you after people have written into us. And thank you all very much for your time this afternoon.